On Talking with Dr. Donna, we focus on 4 pillars of health to help build a generational health network to end the cycle of premature death in the Black community. I created Talking with Dr. Donna as a way to educate as many people as possible and give accurate information from a trusted physician. Go to Talking with Dr. Donna and get accurate information. And then share that information with your family and friends. And if you like what you see, like my channel and subscribe. Remember, every Thursday, keep your appointment with Dr. Donna. Hey, good evening, everyone, and thank you so much for keeping your appointment tonight. Welcome to another episode of Talking with Dr. Donna. Our goal here on Talking with Dr. Donna is to build a generational health network so that we can end the premature death in the Black community. And we do that by focusing in on 4 pillars of health. We focus in on our emotional and mental health. We focus on our spiritual health. We focus on our physical health, and we focus in on our environmental health. Because I firmly believe if we focus in on these 4 pillars that we can help to end the cycle of premature death in the Black community. So tonight I'm so super excited because it's been a long time coming. I've been waiting for this guest to have availability to come on the show, and tonight is the night. So you did a great, smart thing keeping your appointment tonight. You have Thursday at 6:30 p.m. with the doctor. And tonight, you're getting 2 doctors because I am excited that we have Dr. Dawud Lankford with us tonight to talk about prostate cancer. So I'm going to pause right here. If you have any men in your life, I want you to share this page. If you're on Facebook, if you're on YouTube, share it and go live so that people can see this. This is information that we need to have in our community. We need to talk about this, particularly, men are not as good as women about talking about their health. And so I want you to share it out. If you're a woman, just share it with 1 man tonight, okay? And pay attention. Take notes. As always, I want you to amplify the message and the nuggets that you're going to learn tonight. I want you to amplify that and let the men in your life know what they need to be doing, okay? So before we start and I introduce our guest, I want to talk a little bit about why is this topic even important? Why do we need to focus in on prostate cancer and talk about prostate health? And let me tell you why. Because prostate cancer is the #1 cause of, is the most diagnosed cancer in men, okay? It's the #2 cause of cancer death in the United States, and that's just after skin cancer. Over almost 300,000 men are diagnosed every year, and about 34,000 die from prostate cancer. Like any other type of cancer, in our prostate cancer, if you detect it early, we have a really good chance of curing it, eliminating it, and you having a great chance of survival. And Dr. Lankford's going to talk to us about that. So the other reasons why it's important in our prostate cancer, and particularly as we look about our Black men, is because there is about nearly every single day 17 Black men die of prostate cancer, and that's unnecessary, right? As you're going to learn tonight, and as we talk about here on Talking with Dr. Donna, we talk about generational health, and like I said, our goal is to end premature death. This is one of those premature death things because you don't have to die from prostate cancer. About 1 in 6 Black men are diagnosed with prostate cancer, and every 13 minutes, a Black man is diagnosed with prostate cancer. And like all of our cancers and all of our health, there's some disparities there, right? So if we look at Black men compared to white men and the disparities that we see in cancer, we see that Black men are diagnosed about 1 time, like 2 times more often than other races in terms of our diagnosis, but then they're also twice as likely to die from prostate cancer. So nearly 2 times the increased risk of being diagnosed and nearly 2 times the increased risk of dying from prostate cancer than white men. So that's why we're talking about it tonight. That's why we have our guest who specializes in this area talking with us tonight so that you get the information that you need that you can share with your family and friends. So let's find out about Dr. Lankford. So Dr. Lankford is Oakland and Walnut Creek based urologist. He was born right here, y'all. He's a Bay Area boy, born in Berkeley, attended the University of California, Berkeley. We will not hold that against him, okay? He chose the wrong UC. I mean, you know, we all make mistakes in our lives, but it turned out pretty good for him, even though he went to UC Berkeley. And then he got a master's degree. He went to Meharry Medical College, right? So he's a bona fide doctor, went to Meharry Medical College, and also got a master's degree in public health from the University of California, Berkeley. He did a residency in urology at New York Medical College, and then did a research fellowship in urologic oncology at the National Center Institute in Bethesda, Maryland, and then did breakthrough research in genital urinary cancer treatments. So he now has practices both here in Oakland and in Walnut Creek. And we're just excited to have him on Talking with Dr. Donna because, like I said, I've been waiting to have him on our show. So all of y'all out there in Talking with Dr. Donna land, let's give it up and welcome Dr. Dawud Lankford to Talking with Dr. Donna. Yay! Hello, Dr. Lankford. How are you?
I'm good, Dr. Donna, and thank you so much for having me, and thank you so much for such a nice invitation and, introducing me to your crowd, to your viewers.
Thank you. So, thank you so much for being here. And you saw the statistics, you know the statistics, you live the statistics. This is what you do. So first, I want to kind of back off because as I read in your bio, you're a urologist, but you're a urologic oncologist. So tell us, what does that mean?
Yeah, so all the doctors, we have these titles behind our names, and it basically talks about our subspecialty or our specialty. Urologic just means urology, and oncology is cancer. So I did do a clinical fellowship at the National Institute of Health in urologic oncology. They have a branch there that specifically looks at cancers of the urinary system, and that would be prostate cancer.
All right. And so it also means in terms of your surgery and technique that you are specializing in doing robotics, right? Surgery, and that's not something that everyone is trained to do. Is that correct?
Definitely. And that was one of the things that made me sort of interested in urology was the breakthrough technology, innovative technology that we use, one of which is robotic surgery. Robotic surgery has been around now for almost 20 years. And it's been used really aggressively in the United States. And so, yes, I love it. And I was trained to do robotic surgery.
All right. So as a reminder for all of you out there and for you, Dr. Lankford, as well, this is live. So if you have a question, don't be shy. Put it in the chat section, and we have people monitoring the lines. We'll read the questions and let me know that you have a question for either me or, more importantly, a question for Dr. Lankford. All right, so we're talking about the prostate. Tell me, what is the prostate, and why do men have it? What does it do?
Okay, viewers, the prostate is a gland. It's located in the perineum. It's in the pelvis. And it's a gland, basically, that creates a fluid that is contributed to the fluid in which men ejaculate. Also, I like to describe it as a gland that's very close to the bladder. And sometimes as we get older, this gland can get larger and also block the tube that we pee through from the bladder. So it's a gland that contributes fluid to the semen. It's a gland that can get larger as we get older and cause urinary symptoms like difficulty peeing, weak stream. And also, it's a gland that unfortunately can develop cancer.
All right, so that's good. So that's leading me into my next question. So when you have an enlarged prostate, is that the same as having prostate cancer?
Oh, that's a great question, Dr. Donna. And no, it is not. Benign prostate hypertrophy is not equal to prostate cancer. It's completely different. And if you do have benign prostate hypertrophy, that does not put you at increased risk to have prostate cancer.
All right. So what are some of the symptoms of an enlarged prostate? You started mentioning some of them. And then what can men do about an enlarged prostate?
Great. You know, it's interesting because if you Google enlarged prostate issues, I mean, the results will be tremendous. There'll be so many results. And you have a lot of individuals discussing prostate issues. And so it generates a lot of interest. So it's important to talk about symptoms related to the prostate. And those symptoms are difficulties urinating. We basically describe these symptoms with the word lower urinary tract symptoms, or the term lower urinary tract symptoms. And those are symptoms that are involved from the lower urinary tract, right? So those symptoms can mean it could be hard to pee, you know, you could have to push the pee. And we call those obstructive urinary symptoms. And then there's other symptoms like it burns when I pee, or I have a pain when I pee. Those are called irritative lower urinary tract symptoms, or irritative voiding symptoms. And those are two separate types of symptoms that are related to the lower urinary tract, which can also be related to the prostate.
Oh, great. So if you have any of those symptoms, what should any man out there who might be saying, hey, that sounds like me, what should they do?
No, listen, this is what's most important. And I think that this describes a lot of issues that go on in healthcare. I like to describe symptoms that we have in terms of if it bothers me or doesn't bother me. We have a lot of symptoms that don't bother us, right? And so those symptoms are non-bothersome, okay? They still should be evaluated by a doctor to make sure that they're not hurting you, but those symptoms are non-bothersome, right? So there's irritative voiding symptoms and obstructive voiding symptoms that are non-bothersome. You're getting by fine. You can watch TV fine, and you can delay your urination and go pee after the game finishes. Or you can watch your favorite TV show and you're okay. It irritates you, but you're okay. Then there are other symptoms that are bothersome, you know, that they're really hurting your lifestyle. They're affecting your quality of life. You can't finish the show. You got to go right at the good part. You know, and those kind of symptoms should push you to go see someone, go see a specialist, go talk to your primary care doctor, explain your symptoms, because possibly there's solutions for your symptoms to help you have a better quality of life.
Great. And if you do have those types of symptoms where it's bothering you, should you see your regular doctor and then, or should they see a urologist, a specialist like you?
I think you should always see your regular doctor. The regular doctor or your primary care doctor is sort of like your best guide towards a good, healthy lifestyle holistically. And also, when I talk to patients, I always ask them about all of their past medical history, anything that's going on with them, because that sets the stage for the symptoms that they describe. And so I think that the most important thing is to see your primary care doctor, have a great relationship with your primary care doctor, and treat them nice because they take care of you.
That's right. Are there any diseases that have increased risk for developing an enlarged prostate, like diabetes or heart disease, or any of those an increased risk factor for an enlarged prostate?
No, those are sort of unrelated. The benign prostate hypertrophy or lower urinary tract symptoms has multiple causes. Enlargement of the prostate being one of them is sort of has to do with your genetics. Um, I had a old urologist who taught me from Oakland, California, Dr. Floyd, Dr. John Floyd. He told me it's like having big ears or big nose or big feet, having a big prostate.
All right. All right, so now let's talk about prostate cancer, because I know a lot of people out there have heard about prostate cancer and are concerned about, well, how do I know if I have it? What are some of the symptoms of prostate cancer?
Symptoms of prostate cancer. So if you have, when we talked about the prostate, it's a gland in the pelvis in which urine flows through. Urine flows from the bladder through the prostate, through your urethra, out into the toilet or to wherever you're urinating. And so if you have enlargement of that area that's going through the tube that you pass urine through, then you can have difficulties urinating, which we talked about, those symptoms. If you have prostate cancer, you can also have difficulties urinating, like we talked about, because prostate cancer causes abnormal growth in the cells of the prostate. But most prostate cancers are found far before they can cause urinary symptoms, right? And so the whopping majority of prostate cancers are found because of an elevated PSA, which is a lab value that's found in the blood, in which your primary care doctor checks every year as a yearly check.
All right, so that's great. So I'm glad you talked about PSA, because I know that a lot of people have heard about this blood test, and there was some controversy. Am I supposed to get the test? Should I not get the test? So in terms of the screenings, as you said, you may not have the symptoms, but how you're going to detect your prostate cancer is by doing this sort of screening every year. And so the prostate PSA, prostate specific antigen, right? Is that something that you recommend for people for men to get? And if so, at what age would you recommend that they start to get that screening test?
Sure. So first, let's talk about controversy. The controversy of a PSA screening. I think that's a lot of people understand that they need a PSA. You talk to people who go to their doctor, men who go to their doctor, they say, hey, I got a PSA, my PSA was okay. Okay, so the problem with checking any lab value is the onus of the practitioner to act on that lab value, okay? And so when we talk about whether someone should get that lab value or not, which is in this case a screening, we talk about what are the potential harms of someone having that lab value. Is there a harm in checking that lab value and then having to act on it? And is that harm worth or risk worth taking, by checking that lab value? And so here's the thing. If I get this lab value and it's high and I have a prostate biopsy, and what's the likelihood that it will save my life? And they did do this, the data shows us that there is a decrease in mortality with PSA screening. So the data does show us that it could possibly save your life. So originally there was a controversy where they didn't know, or there was a question as to whether getting this lab value actually would save your life, to simplify things. And the data shows that it could save your life if you get this lab value, okay? Now, that's part of the controversy. Now, some people say, well, if I get this lab value and it saves my life, will it improve my quality of life? Right? That was the other controversy or the argument. And that is not as clear because everyone's quality of life is different. Each individual once they undergo the screening and they get the downstream treatments or the downstream diagnostic exams and tests, once they get those downstream tests, it's variable as to whether one person may have a problem with one of those tests and one person may not. But what do we know? We know that PSA decreases mortality. PSA decreases death. Okay. And we know that when we stop checking for PSAs for a period of time, we had an increase in the number of people with cancer that went all over their body. So based on that data and those ideas, I would recommend PSA screening, but also I submit to the American Urologic Association's guidelines and recommendations for PSA screening as well. And the AUA, or the American Urologic Association's guidelines, are the screening, checking PSA. They recommend checking PSA from the ages of 55 to 70, unless there's a risk factor. Your father had prostate cancer, and everybody in your family had prostate cancer, or for some reason, we have genetic indicators of prostate cancer, and there's a lot of genetic tests, and there are some indicators of a risk factor for prostate cancer. And so these individuals, or some people say if you're of African descent, because of the data that Dr. Donna showed earlier, this is a risk factor for aggressive prostate cancer and disproportionate mortality. And for that reason, perhaps you should be checked for the PSA early. Sorry, that was a lot of information there. So feel free to ask me a question to clarify any part of that.
No, that's good. That's good, because what I hear you say is that a PSA basically saves lives, right? Like it decreases the mortality. And when the phase was to not check PSAs, more people were getting cancer detected later. And we know that if your cancer is detected later, it decreases your risk of survival, right?
Correct.
So
Correct.
PSA is recommended. And you're saying at what age again would you start if you have no risk factors, besides being a black male, but nobody in your family has prostate cancer? What is the age in which you recommend getting that initial PSA screen?
I would recommend from the ages of 55 to 70. Now, there are caveats to this. And if someone presented to me with a lot of symptoms, these lower urinary tract symptoms, both obstructive and irritative, then that may cause for concern that something's going on inside the prostate. And that may give me cause to check that PSA a little bit earlier.
Okay, great.
Also, we didn't talk about another quality of life factor that's important in prostate cancer and the prostate, and that's erections, erectile dysfunction, and sexual function. That's another indicator of something possibly going on in the prostate. The nerves that go to the penis for erections go around the prostate. And so sometimes with diseases that affect the prostate, it can also affect those nerves going to the penis.
All right, so that's really good information. So we have an age if you have low risk to start, and then if you have a family history of prostate cancer, and you don't have any symptoms, do you recommend starting that PSA screening earlier in terms of younger than 55?
Yes. If you have a significant family history of prostate cancer, I recommend checking at 40, 45. Previous guidelines started at the age of 40 and we pushed it to 55. So I recommend starting anytime before 55, up to 40, if you have significant risk for prostate cancer.
Great, thank you. Okay, so we talked about, oh, do you have something else?
Excuse me.
No, you sneezed.
Oh, no, just a cough. Sorry,
Okay.
Excuse me.
Yes, bless you. If you have, so we talked about PSA as one screening. And then there was, when I was in medical school, we all had to learn the digital rectal exam for prostate screening. Is that still a part of screening for an enlarged prostate and prostate cancer or not?
Yes, the digital rectal exam is a tried and true uh, physical examination. It's not specific for prostate cancer, but you can locate and digitally palpate and feel a mass on the prostate, which could suggest prostate cancer. Now, in today's day, we have an algorithm of different diagnostic tools that are used earlier or that can detect prostate cancer earlier than when you can actually digitally feel a mass. And so I still do digital rectal exams and still recommend digital rectal exams in addition to PSA, but also additionally, we do imaging with the multi-parametric MRI. That's able to have soft tissue uh, visualization of the prostate and locate lesions within the prostate itself that cannot be felt with the digital rectal exam. And these lesions within the prostate could be suspicious for cancer or are seen as suspicious for cancer on this imaging study. And then we use that imaging study to target those areas for biopsying the prostate. There are also biomarkers that we use. And typically we use these biomarkers when it's difficult to discern whether a patient should have a prostate biopsy or not. And those biomarkers are used, they can be used from the blood or they can be also used from the urine. And those also studies are also used to subscribe a risk to that patient. They will say that this patient's at high risk, low risk, high risk or low risk for clinically significant prostate cancer.
All right. Okay, so we talked about screening. We talked about some of the symptoms, if you have symptoms of prostate cancer, and then we talked about screenings for prostate cancer. So, what if you do check your PSA or you do the screenings and you find out that you actually have prostate cancer? What do you do next?
Yeah, so essentially what we've sort of diagrammed is a patient who has a risk factor or needs to be screened for prostate cancer. Usually that screening starts with a PSA. It goes on to MRI screening, and then also we use the biomarkers as we talked about. If the patient has a biopsy and the biopsy shows that they have prostate cancer, the first question is that cancer, right? And we use Gleason scoring for the cancer. Is that cancer clinically significant? Okay, I want you to leave you with that idea. Now, Gleason scoring, we score prostate cancer from Gleason. Starts off the lowest usually is a 3, and the highest can be a 5. And we have 2 scores, so it's 3 plus 3, and so on. 3 plus 4, 3 plus 5. So the highest can be a 6, combined score, or 10, right? And so those scores after the biopsy lead us to a diagnosis of risk or risk of the cancer. And that risk of the cancer then lends to a conversation about what treatment options. And I know sometimes these things can get very, very confusing for patients because there's the Gleason score that we use. We also use your age, and we also use your actual PSA number. And sort of all of these things are used to give you a risk of if this cancer can become clinically significant, meaning it could either kill you or affect your quality of life. Or if this prostate cancer is clinically insignificant, meaning it's most likely not going to kill you and it's most likely not going to cause a problem with your quality of life. Okay? So in summary, if you are diagnosed with prostate cancer, we need to understand what the risk of that disease is to you. Can it kill you and cause a problem with your quality of life? Those quality of life indicators are urinary function and sexual function. Or is it clinically insignificant and it highly likely would not cause a problem with your quality of life or kill you? And so once we have that data and once we have that conversation, I tell people after they come back from a prostate biopsy, if you don't have prostate cancer in the specimen, we're going to give a high five and we're going to continue checking your PSA. But if you do have prostate cancer in the specimen, then we have to determine, is it clinically significant, like we just talked about, or is it clinically insignificant? If it's clinically insignificant, the treatment option for you is something called active surveillance, where we just watch the prostate cancer and we do nothing other than watch your PSA. And we look at those same risk indicators going forward, Gleason scores, PSAs. And if it is clinically significant, then we talk about treatment options. But let me pause here.
Yes.
It was a lot to digest. I'm going to give Dr. Donna a chance to respond.
Yes.
I apologize.
Okay, so I have a question because I can feel it in my spirit that people are saying, wait a minute. If I have cancer, you're saying to leave it in my body and let's just watch and wait? Is that what you're saying?
Yeah, so it's interesting. We just talked about the controversy of screening someone for PSA, right? Because we want to know if doing this test is going to save your life. If doing a test is just going to cause you harm and it's not going to save your life, then we would not want to do it. So also, having cancer, we want to treat it if it's going to save your life, if it's going to help you. If treating it is not going to help you, it's just going to put you at risk for having problems with your quality of life, and also maybe even do you undue harm, then we don't want to treat it. We want to watch it and we want to wait till it becomes significant enough to give you harm. And that's the subtlety of prostate cancer that's interesting and difficult. And that's why we use shared decision making in prostate cancer, where it's really important to share in the decision making with the patient, because it's we have to educate you about what your risks are if you're treated or if you're not treated, and then you have to educate us about what you want out of treatment and what you want out of life, and then we can come together to get the best solution for the patient. So as you're saying, some patients may say, I do not want to watch my cancer. I would rather have it treated. Then perhaps it's, even though we may think it's not a significant amount of disease, it's significant to that patient or that person. Right.
And so in treatment of prostate cancer, I know surgery is an option. Is that, you talked about the quality of life and sexual function. Which treatments kind of cause an increase in the risk of maybe impacting the sexual dysfunction?
So two areas I kind of try to focus on when we talk about prostate cancer, just generalize and focus on, because it helps for people's understanding, is there's two quality of life factors that we follow, that we look at. And that's the sexual function, which is erections. Can you get erections? And can you have satisfiable sexual activity, which could mean intercourse, and there's urinary function. Can you hold your urine? Are you able to void well with no obstruction? Are you leaking of urine? And those kind of factors. And so those are quality of life issues, right? You're not dying because of not having erections or being able to hold your urine, but it can affect your quality of life and your happiness and your level of happiness.
Right.
So prostate cancer untreated can cause damage to those two issues, those two concerns. Prostate cancer untreated can cause damage to your quality of life, urinary function issues, also sexual function issues. But also, prostate cancer untreated can also cause death.
Right.
for metastasis. So on the flip side of that, treatment of prostate cancer can also cause, I'm sorry, on the flip side of that, treatment of prostate cancer, sorry, can also cause it. It gets a little
Yes.
touchy. But treatment of prostate cancer can also cause damage to your quality of life, you know, sexual function issues, urinary continence issues, and death, right? So before we treat the prostate cancer, right, we have to make sure that it's going to, you know, that you have a equal and equivalent risk of damage to your life and damage to your sexual function and urinary function.
All right. Well, thank you. I want them. Can you put the picture back up with the brown guy and it shows the side view, because I want to see if yes. So if you remove the prostate with surgery, let's say you're treating the cancer, how does that impact you? Can they live without a prostate?
So yes, you can live without a prostate, right? And so for surgery, when you remove the prostate, you have to reconnect the bladder to the urethra, right? So if you can imagine, there's a bladder or there's a balloon, and the balloon is connected to a straw, and that has to that has to go together so that the urine can be stored in the balloon and pass through the straw. And so when the prostate is in between those two, right? So if you can take the balloon and put an apple or an orange or a lemon in between the balloon and the straw, right? That's sort of like the prostate. And so when that's removed and you have to put those two back together, you can live fine, you function normally, and the nerves and everything that go around this object in between the balloon and the straw have to be preserved. Okay, then you function normally as you did prior to the surgery. If for some reason those nerves aren't preserved, or if your cancer has invaded into those nerves and they have to be removed, then sometimes you have no erections or you have limited erections. That area also is important for incontinence to hold urine. So that area also can cause you to leak urine as well. So those are sort of some of the risks of doing surgery and removing the prostate. You can live without the prostate, but you can have quality of life concerns.
Yeah. So let's say you have diagnosed with prostate cancer, you go through treatment. What's the survival like on the other side for people who are treated with prostate cancer? What's their survival rate usually?
Yeah, so the data shows, so we have a study recently that was published out of the UK. It's in the New England Journal of Medicine, and it does 15 years, and it compares the 3 different treatments for prostate cancer: radical prostatectomy, radiation of the prostate, and then also just watching, active surveillance, as we talked about. And it showed that the survival of all 3 groups is quite well. There's very few deaths due to prostate cancer. So the answer to that is that you do well. Most people do not die from prostate cancer. The whopping majority, over 98, 90%, do not die from prostate cancer.
Great. That's great news. That's really great news. To see that more than 99% of people diagnosed with prostate cancer will be alive in 5 years. That is excellent news. Excellent news. All right. Well, Dr. Lankford, this has been extremely educational, and I hope that people out there who are watching are actually taking notes and talking to the men in their lives about the prostate cancer and an enlarged prostate and what to do about it. So thank you for coming on and talking to us about it and educating us, because it's really confusing, right? All of the things that you hear about, do you get a PSA screen? Do you not? Do you treat your cancer? Do you not? So thank you for those explanations. I'm going to see if there's any questions. Yes.
First question is, what does it mean when you have a large prostate but you don't have cancer?
Okay, I think you kind of answered this question, but the question is, what does it mean when you have an enlarged prostate but you don't have cancer? So I know you answered this, but maybe you can go through it again.
Sure, sure. So if you have an enlarged prostate, that means your prostate, and sometimes it's okay to have an enlarged prostate. I'm more concerned, and your practitioner should be more concerned with the symptoms that you have. And so a lot of times when you have a large prostate, you may have obstructive voiding symptoms or difficulties urinating, problems with urination, right? And so the issue with that is that you want to make sure that those problems with urinating is not associated with prostate cancer. So the fact that yours is not prostate cancer is good. But on the other hand, the issue of voiding and urination is the issue that's being treated. So I would say that enlarged prostate is not related to prostate cancer. It doesn't put you at increased risk for prostate cancer, but the symptoms that you feel from having an enlarged prostate can be associated with prostate cancer. And it's important to make sure that you don't have prostate cancer and have that excluded.
Awesome, thank you. And then I don't know if we went through this already, but what are are there any risk factors for developing prostate cancer?
So the risk factors that I commonly look at are family history, paternal family history of prostate cancer. Does your father have it? Does your grandfather have it? Do you have brothers that have it? Also, we look at some of the data for African American people or people of African descent having a higher risk for aggressive prostate cancer. So we're looking at people of African descent as having a higher risk for aggressive prostate cancer. So therefore, perhaps they should be screened early. That's up to the practitioner and also and to the patient with shared decision making. But also, perhaps they should take treatment in situations where they may think they have clinically insignificant prostate cancer. Also, some have looked at some of the breast cancer and other cancers as being familial risk factors for prostate cancer, and related genes, BRCA genes, and things of that nature have been looked at. There are genetic tests that you can take to look at specific genes and groups of genes that can be associated with increased risk for prostate cancer as well.
All right, thank you. Any other questions?
There's one more, but I think you've answered this one. The men live without a prostate.
Yeah, he answered that one. Okay.
There's another question. This is that the statistics talk about non-Hispanic black men. So is there more of a risk with American black men than there are in the African diaspora?
Okay, so the question is about non-Hispanic black men risk of prostate cancer versus Hispanic black men risk of cancer. Is there a difference?
So I don't know of any documented difference between non-Hispanic versus Hispanic black men. I think that racial categorization is more of a social construct than it is of a genetic nature. I do not look at racial categories in my practice. I more look at a family risk. If you have family history, I look at that as being more of a risk than if your race is, or if you look like a certain race. But that's my personal preference. I think that some of these I think that the most important factors are: what is your family history? What does your father have? What does your grandfather have?
Mm-hmm.
Do they have prostate cancer? And associating those risk factors versus just because you're of African descent. Now, one issue that I have found is that some people don't know their family risk factor. They don't know, maybe their parents didn't talk about it. And so in that case, I err on the side of caution and I screen, because if you don't know those risk factors, then you don't know what can hurt you. Um, so hope that
All
helps.
right. Yes, that does. So I know that in addition to doing urology, you're also really involved in just sort of global men's health. So while I have you here as a male physician, is there anything that you would like to talk to just men in general and say to men in general about their health and taking care of themselves?
I'm so glad you asked me, Dr. Donna, about that. But to be honest with you, I'm not, I believe that we all are, one humankind. So it's not just men, it's women, it's human beings.
Yes.
And one of the things that I really believe in is that you should be satisfied with your healthcare and your treatment plan. And that kind of starts with you as the patient. And I feel like the patient is at the center of healthcare. A lot of times you go to a hospital and the hospital is the center of attention. You're at this institution. Or if you go to a doctor and the doctor is the center of attention, hey, I'm this person and I'm telling you what to do. But I would say that the patient, the person who's experiencing the problem, is at the center of the situation. He's the chief, or she is the chief, she is the leader. And I think that people, when you go and you get a healthcare, when you interact with the healthcare system, you go see your doctor, you go to these hospitals, you should be evaluating these hospitals, evaluating these doctors, and really deciding at the end of that visit, are you satisfied with the care that you receive? Do you understand everything that transpired during that visit? And if you don't, it's okay to ask more questions and it's okay to get second opinions, because the pursuit of your health is what's most important. And so I think that's what's most important to communicate to everybody, no matter who you are, no matter what issue or what element that you have, is that you should pursue your health. You should make sure that the doctor, that the staff, and that the hospital system is at your disposal and is obtaining the results and getting the things that you need to make you feel satisfied with what you're receiving.
Awesome. That's great. That's a perfect answer, because that's what we believe here. And I talk a lot all the time about having a dream team. So having your healthcare providers be a part of your dream team. And if they're not working for you, then you bench them and you get new players on your dream team. So anything else that you would like to say before we let you go and enjoy the rest of your evening?
No, I think that I just appreciate the opportunity to talk to your viewers. I'm really excited about healthcare and about what we have in the future in terms of people being able to take advantage of technology and things of that nature to get better and to know more about their health. And please visit me, my practice. It's EuroHealth. I'm in Oakland, California, 3300 Webster Street. Suite 103. We'd love to have you. I'm on all of the social media outlets as EuroHealth, URO hyphen health, HEALTH, or EuroHealth Club is also one of my other call names on Instagram. And yeah, let's do our best to make a healthier world.
All right, you took my next thing. I was going to say, how can people reach you? And there you go, at EuroHealth on Instagram. It's at EuroHealth Club, and at EuroHealth right here in Oakland. Also practice in Walnut Creek, but if you live in Oakland, this is the place to see him. 3300 Broadway, right? Yep. Phone number. Webster Street. Webster, yeah, the other side. Phone number for your office.
Phone number is 510-455-2699.
All right. Well, thank you so much, Dr. Lankford, for being here. You are now a part of our Generational Health Network. So thank you so much for being here. Thank you for all your information. Thank you for all that you do and taking care of our community. So thank you so much and hope to have you back.
For sure.
Thanks. All right, y'all, you heard Dr. Lankford, so this is the opportunity for you to amplify, woo-woo, all of the things that you heard from Dr. Lankford tonight. Make sure you don't keep it to yourself, but you share it with your family and your friends. All right, as always, we always have a food of the month. We are in May, and so we have a new food of the month, and this month, one of my favorite foods, which is eggplant. That is our food of the month, eggplant. And I just had it last night. I had Thai basil eggplant with fried rice and some shrimp. Oh my goodness. Sita, you didn't put my picture up. It was so good. But why do we want to make sure that you have eggplant? What are the benefits of eggplant? So it has lots of benefits to eggplant. It's got lots of vitamins and minerals. It's got high in antioxidants. We've just talked about cancer. Antioxidants are sort of cancer fighters. It can help reduce the risk of heart disease, help to control your blood sugar if you have diabetes, help with weight loss. And it's got fiber if you actually don't peel off the peeling of the eggplant, but you actually eat that as well. That's going to be high in fiber. So this month, let's see what you all do with eggplant. Now, I just gave you a recipe, some basil, some eggplant, a little bit of shrimp, sauteed, put it over some rice. You'll thank me. So let me know how you're eating your eggplant. As always, post it on our Instagram or Facebook, and let's share some recipes and share ways in which you can eat this eggplant, our food of the month for May. All right, so thank you again for tuning in with Talking with Dr. Donna. You can reach me on Instagram or Facebook. As always, you have an appointment every Thursday at 6:30 p.m. with the doctor. So continue to join us and continue to allow us to come and teach you how to live a better, healthier life. Remember, our goal is to build a generational health network to help end the cycle of premature death in Black communities. So thank you for being a part of this great network. All right, that's it. Take care of yourselves, and until we see you next week, be good to yourself and your families. On Talking with Dr. Donna, we focus on 4 pillars of health to help build a generational health network to end the cycle of premature death in the Black community. I created Talking with Dr. Donna as a way to educate as many people as possible and give accurate information from a trusted physician. Go to Talking with Dr. Donna and get accurate information. And then share that information with your family and friends. And if you like what you see, like my channel and subscribe. Remember, every Thursday, keep your appointment.